Hi, everyone. Welcome, and thank you for joining us for Science in the City Global Health Series. My name is Carolina, and I'll be your host tonight. Before I introduce tonight's speakers, I have a few items to announce. If you need to leave at any time, please do so through the wooden doors on your left. The restrooms are located at the bottom of the stairs and elevator. And please re-enter through the blue doors, the ones that you used to come into the theater. So shout out to our Pacific Science Center members in the audience. Can you raise your hands? Nice, just a few. So if you're not already a member, membership has some amazing perks. All Science in the City events are free. We recently launched a new membership called Fusion, just for adults, which provides great benefits, including Science in the City talks, passes for 21 plus events, such as happy hours, members discount, IMAX tickets, and evening laser shows. In addition, all memberships support Pacific Science Center mission to expand access science education in Seattle and beyond. So sign up for membership online at pacsci.org/membership. So tonight's event is part of the Global Health and Development Lecture Series. A huge thank you to our contributing partners for the series, the Bill and Melinda Gates Foundation and the Washington Global Health Alliance, who helped make this series happen. The Global Health and Development Series highlight the amazing individuals and organizations in our region who are working to address health problems that have major impacts in developing countries. Tonight is our final Global Health and Development Series. We brought you the latest research from the brightest minds in the global health field every month for the past 2 years. So a sincere thank you to everyone who has helped make this series such a success. It's also the final Science in the City event of 2019, but don't worry, we'll be back in 2020 with plenty more exciting topics, including indigenizing environmental and conservation sciences, the science of scouting with NHL Seattle, the evolution and biology of friendship, octopus intelligence, and climate anxiety and eco-grief. As always, the best way to learn about Science in the City events is by signing up to our newsletter. And to sign up, go to our website, pacsci.org/SITC. Finally, on to tonight's event. As this is the final Global Health and Development Series event, we thought it was only right that we look forward to the future for the global health field. To lead us through this discussion, please join me in welcoming the director of the Paul G. Allen School of Global Animal Health at Washington State University, and tonight's moderator, Dr. Tom Kawula.
Thank you, Carolina. It's a great pleasure to be here tonight, and I'd like to thank you all for avoiding the usual traffic home and staying around for what I think will be a fantastic group of presentations. There'll be short presentations from 4 early career scientists in the field of global health. They're representing 4 different institutions, University of Washington, PATH, the Hutch, and Washington State University. To start the evening off, we're going to have each one of them come up one at a time and briefly introduce themselves, tell you a little bit about what their work, and then we'll all join together up in the front for the panel where we will have some time for some questions for each of them. So I forgot who our first speaker is. It's Diem.
Good evening. My name is Diem Nguyen, and I'm currently an MPH student in the Department of Global Health at the University of Washington. Just by way of starting out on my sharing about my work and research, I wanted to just take a few seconds, and just pause and think about this question for a second. So what are some of the things that support our mental health? And I'm going to give you a few seconds, and then if I don't hear anything, I'll call on some of you, okay? So some factors that support our mental health. Yes? Community, thank you. Other thoughts? Yes? Our built environment, wonderful. Some other thoughts? Wonderful, yeah. Any other thoughts? Yes?
Access
Access to mental health care, thank you. One last one. Anyone else? Vacation. Yes. I saw another hand over there. Someone? What was that? Yes. Yes. Well, thank you so much for that. So the different elements that you raised here are very similar to some of the things that came up in this image here. And those are social activities, balance, exercise, sleep, social relationships, personal relationships. And so these are some of the things that are very common when we ask about mental health. And these particular pieces here are things that in some ways we can control, right? The actions or activities that we have some control over. So recently I was involved with a health assessment project in the community where I worked with some refugee community members, and I asked a very similar question about mental health. What are some of the things that support your mental health? And interestingly, for the refugee communities, the responses that I received, many of them, in fact, were very similar to the things that were raised here. But in addition, what I found was things that came up were safety, as you can see, no violence, right? Peace, acceptance, a sense of community, a sense of hope. And just no discrimination, no racism. So those are things that came up and were very prominent in the refugee communities. And what I noticed was a lot of these issues were very connected to the social, structural, and conditions, sometimes way outside of the control of individuals, right? And that doesn't necessarily mean that for us, that these things are not important. It's just that in research shows that when you live in stable societies, stable communities, a lot of these things don't necessarily come up. And so you therefore focus on the things that you have some control over, yourself or your social relationships, your immediate community. Whereas for refugees, a lot of times these are things that are outside, so they are running from violence and escaping from war and genocide. And so these are things that came up quite a bit and on the top of their mind thinking about mental health. My current research as an MPH student, as you can see, relates to refugee mental health. I think of my work as a collaborative effort with different refugee communities to make sense of and to rebuild fractured lives. And in a ways, it's working with refugees is understanding and hearing their stories. So a lot of them were devastated by, their communities were very devastated by wars and genocide and ethnic and religious conflicts, and now natural disasters also becoming a prominent issue. And so because of these different events, their lives have been very fractured, their communities are fractured, and their families are fractured in many ways. And so this is how I got involved with this work. Prior to returning, I'm a non-traditional student in many ways, returning to graduate school after 10 years of having finished graduate school. And so prior to returning, I was trained as an educator. I worked in the College of Education at the University of Washington as a researcher and an instructor. I received my degree there, my PhD degree in education there as well. And much of my work related to working with immigrants and refugees. And in this process, I discovered working with the youth, working with communities, is that mental health was a really prominent issue. High rates of depression, anxiety, isolation. But yet what was interesting was that these things were not discussed. These things were not talked about or even addressed. There were not a lot of support for a lot of refugee communities. And so it was that understanding that has led me back to school. I wanted to share this quote from one of my former students, Sen. This is not his real name, but Sen's story really inspired me to come back to school and also to really think about refugee mental health. Sen and his family fled Cambodia. Sen is Cambodian American or Khmer. He and his family fled Cambodia when he was a young child. His family walked through the jungles for over a month to reach Thailand, and then he and his family stayed in the refugee camp in Thailand for 2 years before coming to the US. They were some of the very few lucky ones who made it out of refugee camps and resettled into a third country. Fewer than 1% of all refugees or displaced people, 70 million currently is the number, are ever resettled into a third country, such as the US. And so some family very, very rarely talk about their experiences prior to the US. And so he shared with me one day that talking will break us, that his experiences, his family's experiences, the trauma and all of that were so tremendous that talking about it would always freshen the pain. And it was unbearable to talk about these things, especially without proper mental health support. I wanted to share a few facts about current mental health statistics, right? It's becoming a global health concern. 1 in 4 people in their lifetime will have experienced a mental health problem. And among vulnerable populations such as refugees, 35 to 40% suffer from a mental distress disorder. And among populations such as the Cambodian community that has experienced genocide, between 70 and 80% experience mental distress. Some of the factors that impact refugee mental health connect to exposure, past exposure to war and trauma, to refugee experiences in camp, to their migration experiences, to acculturation experiences with racism and discriminatory practices currently. And then connected to each one of these factors is also additional factors that then weigh down on a person's mental health. I wanted to share this quote from a Vietnamese American social worker that really captures the complexity and the layered effects of the different factors that impact mental health. So the quote, "There's a lot of intersectionality of trauma. We come from a very traumatized culture, historical trauma. Then you add on a layer of coming to America, acculturation stress, and then you add in another layer of racism and discrimination. And so it makes for a really nice mess." My research goal is to work collaboratively with refugee communities to rebuild fractured lives, to really help to shape healing processes that are culturally grounded. So for refugee populations, their sense of identity, family, communities have been destroyed in many ways by war and genocide and all of the various violence that they have experienced. And so all of these different social, cultural components and conditions and structures that we have in our own communities that naturally support our mental health, those have been disconnected, disrupted. And so for many of these families, even though they're here, those things are not in place for them. And so my hope is that I get to work with these families and help to restore some of these natural healing processes for them. So thank you very much.
Good evening. My name is Linda Oseso, and I am the Social and Behavioral Research Science Project Manager at the HIV Vaccine Trials Network, which is housed at the Fred Hutch. This evening, I'll be giving an overview of some of the work we do to engage communities in our clinical trials. So a little bit about my journey into global health. I was born in Kenya, and my interest in HIV research stemmed from conversations with my aunt, Dr. Ruth Ndwati, who really inspired me in her work. She's a pediatric epidemiologist working in the space of prevention of mother-to-child transmission as one of her areas, and that really drew me into the space of public health. And this led to my pursuing my undergrad in public health, and most recently completing my MPH in epidemiology at the University of Washington. In my second year, I started working for the HVTN. So to set up our conversation this evening, I want to ask, we should discuss where the epidemic is. So although there has been significant progress in reducing HIV, the epidemic is still not under control. According to UNAIDS, globally, there are 1.7 new infections in 2018. This is about 5,000 new infections in adults and children a day. And so even though there have been wonderful advances in treating and preventing HIV, we are still not close to our 2020 targets of 500,000 new infections. We continue to need new ways to prevent HIV infections so that we can meet the needs of all kinds of people living around the world. The HVTN is in pursuit of a safe and globally effective preventive HIV vaccine to add to the prevention toolbox. So the HVTN was created in 1999, and it's the world's largely publicly funded, multidisciplinary international collaboration whose mission is to enhance the discovery and drive the development of a safe and globally effective HIV vaccine. This slide reflects the depth and breadth of our work globally. All we do is made possible by the communities with which we work, and the study participants who contribute to the clinical trials. We're part of a global response to end the HIV epidemic, and we share this vision with our public and private partners. So we're currently in over 60 clinical trial sites in 13 countries that are conducting 19 ongoing clinical trials, 4 of which are efficacy trials, and 15 of which are early phase trials, and approximately 14,000 study participants are in active follow-up in our clinical trials. So within the HVTN, I work for the Social and Behavioral Sciences and Community Engagement team. And understanding social, and this is led by Dr. Michelle Andrasik. So understanding the social, behavioral, and economic and political drivers of HIV transmission is critical to the design of HIV vaccine research. And it is core to our pursuit of a safe and globally effective preventive HIV vaccine. So in our work, we're engaging community members throughout the research process to foster trust and mutual understanding. The work of our team reflects the vision of the HVTN and is inspired by the fact that communities are at the heart of our clinical trials. We know that without community, science cannot move forward. I'm going to highlight some of the projects that we've worked on within our group. So the AMP study, those are the logos on the bottom right there, is a new concept of HIV prevention that is related to what has been done in research with HIV vaccines. So in conventional HIV vaccines, a vaccine is given to people, and researchers wait until they determine whether these people's bodies make antibodies to HIV in response. In this study, we're skipping that step and administering the antibodies directly to people. We have done this through an intravenous infusion, commonly known as IV infusion or getting drip. And this is a first study that evaluates whether antibodies are able to prevent HIV infections in people. So AMP is a proof of concept study that will help move science forward. So prior to the launch of this study, our clinical study research site staff voiced concerns regarding effectively communicating complicated concepts of broadly neutralizing antibodies in HIV prevention, the acceptability and perceptions of antibody infusions, and the need for ongoing and novel communication regarding the importance of community engagement in research. So to supplement the efforts and educational materials used by sites, an animated video addressing the concerns was identified as an effective mode of communication. So our team used a methodology called community-based participatory research, and this is a collaborative approach to research that equitably involves all partners in the research process and recognizes the unique strengths that each brings. So using the CBPR method with community and site staff driving the process, we facilitated the development of a set of 4 videos, totaling 8 AMP animated educational videos in 13 languages for 7 of our sub-Saharan African countries, and that is South Africa, Zimbabwe, Botswana, Mozambique, Malawi, Tanzania, and Kenya, 2 of our South American countries, Brazil and Peru, and for our countries, for Switzerland and the US. And these videos were used to engage communities and educate them about this clinical trial. So we have continued to use the CBPR process in the development of other video projects, and I'm happy to share those with you after our conversation this evening. So transgender people are people whose gender identity or expression is different from their sex assigned at birth. Transgender people are one of the groups most affected by the HIV epidemic and are 49 times more likely to be living with HIV than their general population. According to UNAIDS, globally, it is estimated that around 19% of transgender women are living with HIV. Transgender people have low rates of access to health and HIV services, and due to a range of issues such as violence, legal barriers, stigma, and discrimination, to name a few. So in a small sub-study that we're conducting at the HVTN, which is a small sub-study of the main AMP study that I just described, we're exploring what are the site-level barriers and facilitators in recruiting and retaining transgender participants in our clinical trials. And this study is being done in the US and Peru. And this came about because we saw that there were different rates of enrollment in transgender populations across our different sites. And we wanted to understand, is this due to factors at the site, or is this due to factors external of the site? And this study is currently ongoing. So that expands some of the work that we do within the social and behavioral and community engagement team. And I'm happy to elaborate in our conversations this evening. So I'd like to put in a plug for a program that we have called the RAMP Scholars Program. And this is a program that the HVTN has for African American and Latinx medical students who are interested in HIV vaccine research. They get to do a summer opportunity with our organization. And this summer, they'll be going to several of our countries in Southern Africa. And applications for this are due on January 6th. So if you know any medical students, please let them know. And so I would like to end by reading a quote from HVTN's principal investigator, Dr. Larry Corey, who said the following at the International Conference on AIDS and STIs last week in Rwanda. We need a prevention strategy that in Silicon Valley terms is a disruptive technology, and that is an HIV vaccine. I am very grateful to be part of a team that is working to find this disruptive technology that will contribute to an HIV/AIDS-free world. So I'd like to thank the global study staff and community engagement teams, and most of all, the participants who make this journey possible and contribute to the work that we're doing. I would like to acknowledge my team. So this is a team that I'm part of that I've just mentioned, the Social Behavioral Sciences and Community Engagement, led by Dr. Michelle Andrasik in the center. And I would like to give a special shout out to my colleagues, Cody Shipman and Azil Gangardine, who helped me prepare for this presentation. And last but not least, our funders and collaborators. And with that, I look forward to our conversation this evening. Thank you. And one more plug, we have this book here that we're giving out in the front. It's just describing some of our research, and we have these twice a year but that come out, but this one is in the front. So as you're exiting, please feel free to grab one.
Good evening, everyone. My name is Ali Seibel, and I'm a product development engineer at PATH. So PATH is located just down the road, and it's truly a global team of people that are really passionate about improving health outcomes. And one of the ways we do this is through product development. So I'm really fortunate to work at PATH as a product development engineer in one of the coolest office spaces ever. This is an image from our product development shop. We work with cool things like 3D printers and laser cutters, and we have a full machine shop, but the tools are really there so that we can make the most impact we can through what we design. So how did I get here? I'd like to say that this was the path that my career has taken so far, with school, some abroad experience, and then getting the job. But really it looked more like this. So I'd like to walk you through each of the 4 steps I've taken to get to where I am right now. So step 1 for me was becoming a runner. I've been pretty passionate about running ever since I was in high school, and that was about the time I realized I liked math and science as well. And so I decided that I was going to become an engineer and I was going to design elite running shoes. So I enrolled in the bioengineering program at Santa Clara University and soon discovered they did not have a running shoe design emphasis. But they did have a medical device track. And so that's the track I started in on, and I quickly fell in love with it. I really liked the idea of being able to use my love of math and science to create these life-saving medical technologies. I liked it so much that afterwards I got my master's in medical device innovation from Johns Hopkins. But throughout all of this, I kept on running, and because I kept on running, I started getting injured. And through my injuries and the injuries of my teammates, I became specifically interested in bones and why they break and how we can make them heal. And so after I finished up at Hopkins, I worked for several years at a division of Johnson & Johnson designing implants and surgical instruments to help fix complex bone fractures. So the running shoe thing didn't work out for me, but I do still run a lot. This is a picture of me 2 weeks ago. I was on a trip to Ethiopia for my work at PATH, and I got to participate in the largest road race in Africa. So that's me with about 40,000 people behind me. I did not beat all of those people. So that explains how I got interested in medical devices, but how I got interested in global health required a small stint as an international model. My graduate program at Hopkins involved international immersions, and so I got to spend several weeks in Nepal looking into technologies to improve outcomes for preterm babies. And when I realized the impact that thoughtfully designed innovations could have, I was really hooked. I had first started on this work when I was an undergrad, when I got to work in Santa Clara's Frugal Innovation Lab. This is the picture of the green sensor, is an arsenic detection device that I helped design. But I think the project that really convinced me that I wanted to be in this field was working with a huge diverse team at Hopkins to design better protective equipment for healthcare workers treating Ebola patients in West Africa. And it was a great interdisciplinary project. Got to work with nurses who had been on the ground in Liberia, scientists, engineers, a dressmaker, and I realized just the power of people with all of these different backgrounds and experiences coming together to make a difference in global health. Towards the end of the year, they asked to take a couple pictures of me in the Ebola suit, and they ended up in international news outlets, so that was the first and last time I will ever be an international model. And it was ultimately those experiences that I had in grad school that stuck with me through my time at J&J and convinced me that I really wanted to continue to use my engineering skills to work in this field. And so I was able to take a job at PATH, working in their product development shop, and started working on projects for the immunization cold chain. So a lot of my work at PATH is focused on how do we keep vaccines from overheating and also keeping them from freezing. So it's pretty well known that a lot of vaccines cannot be kept at too high of temperatures or else they lose their potency. And that's a challenge in settings that lack electricity. But a lesser known challenge is that it's also quite bad if vaccines become too cold if they're exposed to freezing temperatures. And so a lot of my work at PATH has been trying to find that sweet spot. So I get to use my knowledge of thermodynamics to help create technologies to prevent vaccines from freezing. But it's a very interdisciplinary effort as well. And so a lot of my work has focused on looking at a pilot study we've been conducting in Nepal. So the picture is actually the same hospital that you saw me in from 5 years ago in the slide previously. And we've gotten to do data analysis and talk to healthcare workers and figure out what they like and don't like about the new technologies and figure out what changes we can make as engineers partnering with public health professionals to make sure that when we work with the local manufacturers to release these devices, that people will actually use them. But what I've realized is that simply getting to the job in global health isn't the end point. There's always so many more questions to be answered, and that's something that I really like about what I do. So this is just a small sample of the questions that my colleagues and I ask on a daily basis. We're really passionate about making sure that everything we design really keeps the users at the center. And so a couple quick projects we've worked on. In the top left, we've been working on a project to better keep track of hundreds of thousands of vaccine vials during massive polio immunization campaigns. And we've been interviewing healthcare workers in countries all over the world to get feedback on that. In the picture on the top right, we've been looking at low-cost ways to help make sure that babies born in low-resource hospitals that have trouble breathing have the same chance of survival as they would have in a higher-resource hospital. In the picture in the bottom right, that shows an example of one of our successful partnerships with local company MSR, Mountain Safety Research, taking a technology that used to be used for helping campers purify their water and figuring out how to adapt that so it can be used for humanitarian applications. And then in the bottom left, as an example of work that our formulations team does to take existing vaccines and medications that are extremely effective and figuring out how to make them so that they don't require the immunization cold chain anymore, so making them more widely accessible. So I'm really excited about all the work that we do. I'm excited about the awesome people that I get to work with, and I'm glad that I get to keep working on finding answers to all of these important questions that we have in the field of global health. And with that, I look forward to hearing your questions in a couple minutes. Thank you.
Good evening. My name is Eric Osoro from Kenya. I will not have slides up there, but I will do the presentation from right here, so I'll be the slides. I work for the Washington State University Global Health Program in Kenya as a medical epidemiologist. Many years ago, I trained as a medical doctor in Kenya and worked in clinical medicine for some years before I moved into public health and specifically into epidemiology and research. And the area I work in global health is the area referred to as the area of emerging diseases. Emerging diseases are these diseases which are becoming, in terms of incidence, they're becoming more frequent in the last decade or so, or they're occurring in places where they did not occur before. An example would be like the Ebola outbreaks. We had an outbreak 3 years ago in West Africa, which spread to Europe and even to the United States. So that is referred to as an emerging disease. And emerging diseases are important in global health because of their consequences, both in terms of the number of people affected, but also the economic consequences because of aspects of restrictions in trade. And the reasons why we're having these diseases is there are 2 or 3 main reasons. One of them is environmental, in the sense that because of the human agricultural, agricultural aspects, and because of encroachment, let me call it encroachment, we are allowing the human beings to interact with microbes which they were not interacting before, and these microbes are able to cross what is referred to as the species barrier. So pathogens or microbes which were initially affecting animals are now able to cross over and to infect humans. And this results in these emerging diseases. In fact, about 3/4 of the emerging diseases are from animals to humans. And they're also called zoonotic diseases. Examples include yellow fever, include Zika virus, and I'll give 2 specific examples. Another reason why we have this is also things to do with the modernization and urbanization. We are mostly moving towards cities, and there are aspects of overcrowding, sanitation, especially in the developing countries, which are resulting in these microbes causing disease in humans. So the area I work in is in this sphere of global health referred to as emerging diseases. So I want to give 2 specific examples of the 2 research areas I work in. One is on the Zika virus. Zika virus, if you recall, about 4 years ago, caused devastation, especially in South America, where it was associated with the birth defects. The specific birth defect it was associated with was children who are born with small heads, microcephaly. And this is a serious public health problem because such children are not able to grow normally and normally require a lot of support, and that is considered a serious public health challenge. Now, Zika virus was initially discovered in East Africa in a country called Kenya. And though there were cases there reported of children born with microcephaly, no one had associated that with any viral infection until we started seeing the cases in South America. So our study was looking at pregnant women in Kenya and trying to understand whether the Zika virus causes the cases of microcephaly, which have been seen in Kenya previously. And we have enrolled about 1,200 women, pregnant women, and we follow them up monthly, test them for Zika virus, and also assess the children once they are born to determine whether they have these complications which are associated with the Zika virus. And the Zika virus is a virus which is transmitted by mosquitoes, the same mosquitoes which transmit other viruses such as dengue fever, which is now a disease which is now occurring in many places of the world, including here in the United States. The other example I want to give is about a disease which causes a severe respiratory illness caused by a virus which is a coronavirus. And this was initially detected in the Middle East. Therefore, it was called the Middle East Respiratory Syndrome. In short, it is MAS. That was in 2012 when it was initially detected in Middle East, but now it has spread to over 27 countries actually, including many countries, the Middle East, South Korea, in Europe, and even in the United States. The disease is caused by contact with camels. So persons mostly who have the disease will report history of contact with camels, and this virus has been detected in camels. So most scientists believe that it's caused by contact or by transmission from camels to humans. Now, this, though has been detected mostly in the Middle East, this phenomenon has not been seen in Africa. Where I come from in Kenya and the East Africa region in general, is home to 70% of the camels in the world. So you will expect that if we have this disease which is associated with the camel exposure, then most cases will be in Kenya and in East Africa in general. But that had not been documented. So we are conducting this study among persons who keep camels. And the interaction is the camels are part of the livelihood of these communities. The camels are very drought resistant, and most of these communities usually live in areas where there isn't enough water. And therefore, camels are very close to them. They are the ones which give them milk, and they also a source of meat for the communities. And therefore, we are doing this investigation to determine whether this virus is also causing infection in humans, because the fatality is quite high. People who get the virus, about a third of them usually die. Although we have recorded antibodies in the camels, we have not yet detected the disease in humans. And it's possible that the virus which has been seen in Middle East is different from the one which is in Africa. But we have to do our research before we can document that. So those are the two examples I want to give in the area of emerging diseases which I work in, and also welcome you to further engagement as we move into the discussion section. Thank you.
Maybe the hardest thing is we each get to get on these chairs without knocking them over. Yep. So and I think tonight is a night where we invite active participation from you. All the panelists have agreed to field your questions, and what I'd like to say, if you have a question, if you feel free, if there's a certain person you would like to direct that question to, go ahead and do so. If you have a question for the panel, we'll hear the question, and I will look at their faces and gauge which one may or may not like to take that question. First up. Did everybody hear the question? How do you know a vaccine works if you don't know if they've been exposed to the virus?
Well, so it's the populations, we test them, the study is done in populations that are at highest risk. And so we don't give them HIV, right? So actually, let me pause. Repeat your question. How do you know a vaccine works? We're not. We're definitely not doing that. Yeah. So I mean, so the goal is that the viruses are being tested in places where the epidemic is high, right? And so there's considered higher risk populations, or populations that are at highest risk of HIV, or key populations is what they say in global health. So in like the study that we're doing in the US, it's amongst transgender populations and men who have sex with men. In sub-Saharan Africa, women have the highest incidence and prevalence of HIV, and so that's the populations with which the vaccine is being tested. I don't know if that really answers your question, though, but we don't, what's the best way? Can I ask for some vaccine support and how to answer that?
Yeah, so.
Okay, not specifically to the ones they do, but my experience about the way they do the HIV vaccine test is that, for example, in a population where there is high prevalence, for example, in East Africa, it will be a trial. So they'll give some people the vaccine, and the others will just undergo the normal prevention mechanism. And then they'll measure the incidence in the people who received the vaccine and those who did not receive the vaccine. They look at the incidence of HIV in that group and the other group, and then they can determine whether it's working.
Right here.
My question is for Dr. Nguyen. I work with young refugee adults and the ones who bridge the gap between their parents and grandparents who come here and they know nothing about the culture, and they may have come here as young adults, but they've learned enough to become acculturated. So on top of everything they do every day, they also serve to take care of their parents. They serve as a bridge for the community. Health stressors, this community.
Thank you very much for your question. Yes, this is, right now I'm involved with a coalition of organization here in Seattle that is looking at different generations. And the group that you're talking about is very much a part of that. And just in general, the issues of intergenerational and cultural gaps between the different generation is a tremendous source of stress for families, adding on to a lot of the different things that I had talked about in terms of acculturation. And it hasn't, in terms of the research up to date, there hasn't been a lot of research done, but it is something that in King County we are looking at, trying to understand better ways to support the different generation based on their needs that they have. So thank you.
Thank you.
Hear any of you comment about how you feel about how your field is covered in the news?
I'm checking the faces. Allie, why don't you give it a shot?
Sure. So I think sometimes the media can make things look a lot worse than they are. Like, you don't hear a lot of the good news in global health that's being reported. You only hear about, the dozens of polio cases that have been reported this year, which is bad and that deserves attention. But you also don't hear about the massive gains made in immunization over the last couple decades, on like the truly incredible advances that are happening. So I think sometimes global health can seem a little bleak if you're only paying attention to the media, but I know from talking to my colleagues that even when seeing some of the setbacks and sometimes things working a little slower than we'd prefer, it's still a really inspiring field to be in, and seeing over a couple decades what a difference these interventions can make.
And I agree, especially with vaccines, right? There's a lot of stigma and assumptions about what you're infecting people when you're not. And so a lot of what our team does is community engagement. The community engagement side is going into the community and educating folks about the work that we're doing around vaccines. What is a vaccine? What does that look like to be in a clinical trial? What are we actually doing, and how does it fit in the space of HIV in general? And so I think community education is how we combat some of that, the stuff that's produced in the news, or fake news, should I say, maybe.
Yeah, I would like to add to that as well. I think looking at refugee experiences, a lot of the news coverage is often very much tied to the moment, and so and the politics that's in place at the moment, right? So what we often hear about in terms of refugees is that there's this fear in our country right now of those folks coming here, right? And so it's very, the coverage is often very distressing, because what we know in terms of the statistics is that less than 1% of all displaced people, right now there are 70 million people that are displaced, less than 1% are actually coming and getting resettled into a third country, such as the US. But if you look at the news, it seems like there are a lot of folks coming into our country. Washington State is one of the places where we are receiving refugees more than other states in the country. Washington and Texas are two of the top states. But in the last year, I know that Syrian refugees have been high on in the media, but we have not received any Syrian refugees at all because of the ban on Muslim refugees. And so it's the reality is often not what you see on the news. And so I guess take it with a grain of salt and really dig into the issue a little bit further if that's something that is of interest to you. Thank you.
Okay, in the area of emerging disease, media coverage is episodic. When we have the outbreak, everyone is talking about it, if it's about Zika, but once it goes down or if it's sustained for too long, then the coverage will move elsewhere. But the scientific community generally is left trying to grapple with the problem until we get the next disease outbreak.
I'm curious, Eric, I'm going to put you on the spot just a little bit in that, we all are working globally, but Eric, you're living 99% of your days in Kenya. And I'm curious about, the media coverage there. Can you compare and contrast it, or is it the same thing? You still get the episodic reports, and maybe somewhat.
Yeah, it's also episodic when we have the outbreak, when it's in the heat of the moment, when it's hot, everyone is talking about it. Unfortunately, there's usually a negative angle to it, especially it's compared to a previous outbreak, whether it was a similar disease or otherwise, suggesting that why can't the health authorities manage these things better? Can they, if they had an outbreak last time, and why is it happening again this time? And a little bit of using benefit of hindsight to say, maybe last time you didn't do as well as you should have done. But normally all these are based on after the fact, because for those who've worked in emergencies, sometimes it's not very clear, so you have to act on what is known, and then later sometimes you find that maybe you should have taken other actions. But it's also episodic, with more sensationalization towards asking why the health authorities are not doing enough.
Just right here.
Thank you all so much for sharing about your amazing work. My question is for Ali.
Sure, yeah. So the question, if you didn't catch it, was what does PATH take into consideration when we're looking at whether we should scale an existing technology or create a new technology? And it's a really important question. I think sometimes there can be a bit of a stereotype against of kind of like the overeager engineer in global health who just wants to invent something new and throw it at a problem. And that's definitely been an issue in so many fields, but in like the digital health space, for example, there were so many apps that pop up in light of episodic things like outbreaks, and nobody's really coordinating them and figuring out how to work together. In that area specifically, PATH is doing a lot of work in bringing together a lot of the digital health stakeholders, so taking people who are working on technology development, but also talking to governments of countries and people who have the ability to actually implement them, and saying, how can we work together on this problem so we don't have a million apps that do basically the same thing and none of them are talking to each other. But I think a good example of an area where PATH kind of had to make a decision about whether the existing technology was suitable was the continuous positive airway pressure graphic that I showed up really briefly, but it's a technology designed to help improve breathing for babies that are born preterm. And one really crucial component of those systems in higher resource countries is being able to take oxygen that comes from an oxygen tank and blend it to the right percentage so that you're not giving the baby too high a concentration of oxygen. So technology to do that does exist in higher resource settings. It's a box that can cost up to a couple $1,000s, but it does the job very precisely. And so that you could say, so one approach to solving this problem, right, is to scale up access to that piece of equipment. But the approach that PATH decided to take was creating a low-cost plastic component that costs just a couple cents to manufacture that blends oxygen with room air and can be added to existing tubing. So I thought that was kind of a cool, creative example of realizing, like, yes, this technology exists, but sometimes the barriers to distribution make it so that there might be a better solution to create something that's a little bit more affordable. But the percentage of engineers at PATH is actually pretty small. We rely on so many public health experts who talk to people within the ministries of health and all the NGOs that work in those areas and people on the ground and healthcare workers. And we try to get to the root of what problem are we actually trying to solve there, and is the issue that we need to do a better job of scaling up this technology, or is it really that no adequate solution exists? So I hope that kind of got at your question.
Thank you very much for sharing your story. I don't necessarily look at specific regions in terms of refugees and their experiences and mental health. But I think that current research from the WHO is indicating that broadly looking at, and you're right, that mental health is something that is very much often on the back burner, something that is it's secondary. You know, when you have all these basic things that you need, clean water, you know what I mean? And then there's a lot of health outbreaks, that disease outbreak that's happening in the camps. So mental health is something that is so secondary. You know, we don't even think about it, but it's looking at the stress that the refugees accumulate over time from the constant war, the violence that's they're exposed to, and then the refugee camps experience. So over time, what we know is that these stressors, these exposure to trauma, it gets accumulated, and it doesn't have an outlet. And so that's part of why not everybody necessarily, right, that experience are exposed to these things experience mental health. But for a lot of the refugees, they are experiencing mental health. And so it's coming here that you begin to realize that even in this very safe and stable condition that refugees are in, that we begin to see things like depression. Depression is so high among refugees who are seniors and also with youth. And so we have to ask what's going on with that particular community. And so those are the kinds of questions that we're asking, but not necessarily per region in terms of what's happening. But I would imagine that in the refugee camps that you're talking about, that mental health is also very much a problem there. If, you know, after you look at all of the basic needs of the communities, that you look at mental health, that's a big concern, so. Yes. Thank you. Yeah, thank you. Maybe there's something we can talk about after the talk. Yeah, happy to. Yeah.
May I offer a resource? The International Medicine Clinic at Harborview is very engaged in that.
Linda's not looking me in the eye.
No, I'm thinking. I'm happy to. It sounds like you want me to begin.
Yeah, well, no. I've just noticed.
No. I was looking here and thinking, sorry. No. I will look at you.
No, if anyone, feel free. No. I won't pick on anyone. Yet. Yeah.
Okay.
Yeah.
Let me go first.
Yeah.
In terms of what the future looks like, the area of emerging disease, what we know or what we think is that there will be an emerging disease, maybe in 1 year, maybe in 2 years. Not clear when it will occur, but it will happen. The tools we have right now cannot clearly predict when it will happen. One of the more feared disease or outbreak which could be most devastating is influenza. If we had a pandemic influenza, which was severe and was severe in humans and causing death, that's the one which is the feared one. So in terms of what is happening, I would say there's better coordination in the world currently, especially after the Ebola outbreak. Countries are talking more. The coordination through the World Health Organization and other countries has tremendously improved, and there is information sharing across the globe. So the hope with that is that once a problem occurs somewhere in this globe, then it will be detected early, and the containment will happen before it spreads to other continents. There are actually regulations called the International Health Regulations, whose implementation is improving, which provide for a framework for preventing or reducing the impact of these emerging diseases. So I would say it's both. I would say it's pessimistic because we think we'll have an outbreak when it's not very clear, but then we now, I would say the world is better prepared as far as information sharing is concerned than probably 5 or 10 years ago.
So as I work in the field of HIV, I would say I'm optimistic that we will have a vaccine one day, and that I believe in that, right? I have to believe in that to do the work we do, and also to believe that because we're saying we're hoping to end this epidemic, right? So, and the progress we've made in the past 40 years has been very significant, and so I'm hopeful that we'll continue to make that progress. But I'm also, I guess, not afraid, but uncertain of the uptake of some of the prevention tools that are available, like PrEP, and whether those will be, if countries have enough funding to space out to be able to invest in some of those products or to invest in treatment versus prevention. Will there be challenges in investing in both, which they are right now? And so some are focusing more on treatment with a little bit of prevention, but we need the combination to really tackle and end HIV. So I think that's where my concerns would lie.
So my pessimistic answer is also going to be around pandemic preparedness, but he articulated that really well. It's a really health systems level problem, and it's really difficult to fix all of the health systems globally. But another area is antibiotic resistance, a growing issue really all around the world, and there's not much in the R&D pipeline coming out to address that. So that's something I'm kind of nervous about, but I think there's a lot to be, as I said before, I think there's a lot to be optimistic about in the global health world. Within my field specifically, I think it's really encouraging how within engineering and technology, I think people are getting a lot more mindful about what we're designing and why we're designing it. I think there's been enough backlash now about like so-called equipment graveyards in countries where technologies just get shipped over and there's no sustainability and no maintenance plan. There's growing awareness that that's a problem, and that's something that we want to avoid. And the engineers I meet in global health are really committed to having these like user-centered design approaches, which sounds like a buzzword, and it's only because I haven't come up with a good synonym for it to use instead, but really focusing on the people that'll actually be using the technology and getting feedback from people before we design something instead of forcing it on them after. So it's just encouraging to see those trends, and I'm seeing more and more engineers who are really interested in global health and want to go into global health, which is exciting because there aren't a ton of opportunities for engineers in global health yet, but I think that'll grow as all of these people with really interesting and diverse backgrounds start to become more interested in using their skills in that way.
Yeah, for me, I think I feel very optimistic that we are having conversations about mental health in refugee communities. Globally, that's happening. And so that's a very that's a great step forward, I think. What I am feeling a little bit daunted by is that there's a lack of resources. And so even in the US, one of the countries that has some of the top resources for mental health, we are also lacking in terms of adequate resources. So thinking back to countries that currently in a lot of the Middle Eastern countries, like for example in Lebanon, there's one psychologist in all of the country, right? And so if you go to refugee camps, they're not even talking about mental health. And so that's a very daunting process. But at the same time, having conversation is very hopeful. And so I'm excited about that, and excited to also work with communities. And so one of the things about mental health is that we're learning that a lot of the traditional kinds of social structures that I talked a little bit about in my talk is that some of those structures are also part of the healing process. And so how can we restore those and sustain those and strengthen those? And though maybe that is another way of expanding resources. So that's helpful for me. So thank you.
Thank you for the question. As you mentioned, one of the drivers of emerging diseases is climate change or climate change. For example, as there's global warming, some parts of the world become warmer, then some of the like the mosquitoes, the vectors, are able are able to reproduce in those areas. For example, in the US, I believe there are, because of global warming, the areas where mosquitoes were for dengue, which didn't have dengue, but now are starting to have dengue. The same is happening across the globe. Areas which didn't have these vector-borne diseases, like the mosquito-borne diseases, like dengue, like malaria, are starting to have such diseases. And the challenge of that is that you find the population does not have immunity against those illnesses, those viral illnesses, and therefore the initial cases are usually very severe. So global warming will generally result in that. Of course, you could also argue that there are places which will become too warm for some of these vectors, but most of the population which will be affected will be in the places where the vectors will be able to be propagated. The other issue about the global warming is that it allows for some of the pathogens to adapt, say the bacteria, and that adaptation can result in more infections and could result in outbreaks. And therefore, all this global warming generally, as far as global health is concerned, or as far as emerging disease is concerned, is looked at as one of the key drivers in the causation of either new disease caused by new pathogens, or pathogens becoming more virulent or causing more severe disease because of the change in habitat or change in the ecology. Thank you.
Going to other countries to solve their problems, that there needs to be built capacity. And as that space to move toward that, because even though there's conversations, that's not toward that trend of moving to increase capacity. Actually happening, like the gentleman over there was talking about, or being more culturally appropriate.
So that's a timely question. We actually had a lunch and learn at PATH today called Removing the Legacy of Colonialism in Global Health. So these conversations are happening, which is exciting and really, really important. I think one thing we're starting to do at PATH, which is exciting, is, I'm going to throw out another buzzword, but co-creation. So the idea is we're going being one, having strong country presences in our offices and having them be run and staffed by, I think 95% of the people in our country offices are natives of those countries. So it's not people from Seattle running offices elsewhere. But then not just having a strong country presence in that office, but actually working with the people in those communities to design solutions. So this new effort's working on how do we get healthcare workers from the local communities and get their ideas in a brainstorm session? And how do we keep going back to them for feedback and making sure that they're really bought into this concept? So I'm excited about things like that, but I do acknowledge that there's definitely been a lot of missteps in the global health community in the past, and there's a lot more work to be done.
If I may comment, the area of HIV probably is an area where you can say that the support from the international community, especially in sub-Saharan Africa, has really propped up the health system. When we talk about the health system, one of the key components is the workers who work there. And you find that in the sub-Saharan Africa, the ratio of health workers to population is really low. There are very few doctors, for example. But we have these physician assistants who, especially in HIV care and treatment, these SOPs which were guiding them were developed, and this provided an avenue to allow them to manage these patients. So there were very clear SOPs on what you need to do when you get a patient, how you need to treat them, and these allowed people who are probably not doctors to be able to provide treatment for millions of persons with HIV. So that's an area which I think help prop up the health system, and especially when it comes to the health workforce, by providing very clear SOPs, which was initially supported by international collaborators, but then it was cascaded down to the countries up to the community levels.
Can you shed more light on why the HIV vaccine?
So this is not my strength, but I will try my best. So this is one of our clinical trials that we're doing and so I guess let me backtrack. So it's looking at broadly neutralizing antibodies as a type of antibody we're testing. And in this particular one, we just, as I mentioned, it's infusing, we're using infusion as a mechanism to see if this, by infusing participants I believe it's every 2 months, with this, can it protect? It's the first trial we're doing. The science behind it I can't fully explain at this particular moment, but so I'm actually having a challenge. So my apologies. Maybe we can connect after, and I'll be happy to. Yeah, sorry. Okay, thanks. Okay. That is another lab-related question that I have heard of this, but is not my strength. So I'm unable to answer that right now, but I'm definitely happy to connect you with my colleagues. I guess my question was so is this the one with the two, I think it's the girls, the twins or something that? Okay. There's no cure for HIV, but they are working towards one. So I wouldn't say that they have one now.
So about HIV in general, they have these conferences, many conferences where scientists meet and share ideas and share new strategies. And I think there's a lot of sharing. So if it's something which is replicable in other areas, then it will quickly get into the prevention strategies and could be applied to the HIV prevention if it is shown to work in other settings. Yep.
There's a question up here. Yes.
Yeah, my question is for Dr. Nguyen. So resources for mental health, and so hand in hand with a lack of resources.
Yeah, so the question is about access to mental health resources here, the resources that do exist, and how insurance play a part in that. Is that right? You know, it's a really tricky one. Even for the mainstream population, that is a big issue of looking at mental health. For refugees, my experiences, so I should let you know that, so this is my new area of research for me, so I'm in the middle of doing this research and trying to understand what all of the complexities of related to mental health in the refugee communities are. And so I don't have necessarily answers for all of that, but in the research that I'm currently doing, repeatedly access to mental health comes up, and insurance is very much related to that. A lot of communities are also understanding that even with access to mental health, the resources or the services are not culturally grounded or culturally appropriate. And so in many communities, issues of stigma come up. And so you don't even talk about mental health, but they recognize that there's something wrong. And so how do you talk about something you can't talk about? And so that's also an issue in addition to once you get access to mental health. I don't know if that answers your question, but it certainly is a big problem. So. Absolutely, a very challenging question for me as a researcher. My colleague here, Linda, talked about the community-based participatory research. That is also a model that I have been using, and what I'm trying to use that model to do is to work with communities and help the communities to communicate how to, so one of the problems has been that we often, as Western, I define myself as a Western researcher. I was trained very much as a researcher in that sense, and so I'm also trying to break away from that way of thinking about research and approaching it from the ground up, from the community base. And so a lot of my work now often involves listening. And hearing what communities are saying are part of the words that describe what are the ways that they're describing as mental health. A lot of times they don't want to use the word mental health because there's something related to mental illness that is not what they're experiencing, not the severe level of illness, but the distress. And so what I'm trying to do is listen to how different communities are talking about it. And then from there, how do we build a language around that? How do we talk about some of these things that's happening in their community? So I'm still learning that, and maybe in a few years I have a better answer for that. But
Okay, the virus is MERS is Middle East Respiratory Syndrome. It's a virus, a type of virus called coronavirus. It has been detected in the Middle East, people who had contact with camels. But in Africa, where we have, or in East Africa, Kenya, where I come from, where we have 70% of the world population of those camels, we have not detected that in the humans, the people who take care of the camels. It has not been reported. So that's what our study is doing right now, because what we found in the initial study is that most of the adult camels already had antibodies to the virus, suggesting that they don't get the active infection. So most likely they get it when they are young. So we are doing the study among camels as soon as they're born, young camels, and also looking at the herders, the people who take care of the animals. It's very possible that it does not cause very serious disease. The African strain, for example, does not cause serious disease in the herders, and that's why we are not seeing many cases coming to hospital or even dying. So that has not been the disease. The virus has not reported among camel herders in Africa or in Kenya, and that's what we are investigating, whether there is actually that virus occurs, but that probably it's a mild disease, and therefore does not reach the public health authorities. So far, there have been at least 900 deaths, and what it occurs is that there was one large outbreak in a hospital in South Korea involving tens of people, but it tends to be sporadic. So the cases will occur in clusters. Maybe you'll have 15 cases, we'll have 10 cases, and it doesn't get sustained because the virus has not acquired the ability to be transmitted from a person to another person. It only comes from camels to a person, but then doesn't move to another person. So that's why it tends to be very localized and only among those who had contact with camels.
Anyone?
If I got your question well, you asked that we have been talking about viruses and what we are afraid of. Okay, so viruses, there's a way the viruses are actually classified based on their severity, on their probability of causing death in humans. There are those which are called level 4, for example. That usually refers to a containment, to how much care should you take when you think you have that virus. So the Marburg virus, for example, the Ebola virus, those are very high containment. They are called level 3. And the others which are level 3 and level 2. The virus I fear most is the one which is transmitted by the respiratory route, by sneezing, for example, by us talking here, and also which causes severe disease in humans. The flu currently does not cause too severe disease, but if we got a pandemic which was causing severe disease, then that will be something I'll fear most. So the transmission, especially the respiratory system, is very key. It can cause a lot of disease, and if the virus also causes severe disease in humans, that's the combination which will worry me the most.
And now I'm worried about those as well.
I'm trying to think. What are we most afraid of? Because people are working on things to help, to move the process forward. I guess I would say Zika, in the sense that if I was planning on having a child, right, and it was that time of time, I'd be afraid of that. I genuinely be afraid. But I know there's progress being made, so yeah, I'm hopeful. But also, I was learning recently about female genital schistosomiasis, and I think that's contracted by worms in the water. Please correct me if I'm wrong. And so I know there's treatment to prevent that, and the process moving forward. But the fear of that, if I went to a place where there was stagnant water, or there's water and I didn't know, and so I had these complications moving forward, I think that would also that would be something I'd be scared of.
Finally, one from the right. I can answer for you if that's it. No.
This might be cheating because there would be a technology component of it, but I'm really interested in improving access to surgical care around the world, and that's something that not a lot of global health organizations have a strong presence in. Surgery is expensive, and it can be hard to, when you have interventions that are really low cost and life-saving, it can be hard to justify pouring $10 million into things where that payoff might not be quite as clear. But as expanding access to surgery it touches so many different systems, from needing to have doctor education, to needing to have the correct surgical supplies, to needing to have the facilities with which to do surgery. So that's a field that I think could use a little more investment, especially as a lot of the global burden of disease shifts from these infectious diseases to injury and non-communicable diseases.
Okay, where I come from, infectious diseases are still a significant cause of disease burden. And one of the best bullets we have against infectious diseases is vaccines. We have these vaccines which work very well. There's the measles vaccine, there's a vaccine against some bacterial pneumonia, but we are not able to reach to every child who needs to get that vaccine. So if I had $10 million and I wanted to cause the greatest impact as far as global health is concerned, which is reducing the deaths and even the morbidity, I'll put that to ensuring that those people who need vaccines, especially the children, do receive the vaccines even in disadvantaged communities.
I'm an educator at heart, and so we very, very rarely get that kind of money in education. And so I'm going to use it for education. And I've been thinking a lot about within refugee camps, because to create some stability and to help help with resiliency amongst the youth, I think that would be worth $10 million if you have any to share.
And I agree with education, but also infrastructure. I think University of Washington and University of Nairobi and also Washington State University have models of where they train researchers who then go back home and do the work, right? And continue to do that work. So I think I would put my money towards that, because you're building the capacity for longevity, and we're trying to figure out something that's sustainable. So that's where I would put my money.
I think that we are wrapping up with time. Oh, you're standing up now. We definitely are wrapping up in time. So I'm going to get in the last question. Since I'm sitting here, I'm going to put in the last question. So in my position, I'm often speaking with people in the state and in Washington, D.C. sometimes, talking about what we do in global health. And I always get somewhere in that room, I get the question, we have many problems here at home. Why should we be investing in global health? And I'd love to give each of you an opportunity to, how would you answer that question? Pick your order.
So the broad definition or description of global health are those challenges, usually we'll say diseases, which cannot be controlled just looking at one country, for example, or which require a multilateral, multi-country approach. And infectious diseases, so these diseases we talk about, the emerging diseases, usually sit right there. Because of the travel we have, we can be anywhere in this world within 24 hours, and you can be incubating or having disease before symptoms occur, and then when you land in another country, then you have the symptoms, and you quickly start an outbreak. We had Ebola in a very remote area in West Africa. It was there for some months, and then we started having it in various countries. Another disease, if you call, there's one which was called Sars in the mid-2000s, which was initially reported in Asia, in Hong Kong, but spread to North America, Europe, in a matter of weeks. And the economic burden was significant. The travel advisories were also very devastating. So I will say that the best way to solve some of these challenges is to ensure that we have either systems to detect them, or we actually have an ability to stop them where they are occurring.
There's a quote by Mandela, which I can't say the whole thing, but it talks about brother's keeper and the concept of that for those, also for those who much is given, much is expected. And so I think if we have the resources, and I understand we have things going on at home, but if we have the knowledge and resources, it is our imperative to share that. Because we are a globe and we all matter. And so I think that's why I think it'd be important to focus on global health. It's not issues that are only happening at home. It's important to care about those around us.
Yes, it's very much a question I ask myself. And the work that I do is very much from local to global and global to local. And where I started in terms of education, it is right here at home. But I also see the need to do global health research in refugee and mental health, because it really does connect to the rest of the world.
I agree with everything that all of the panelists said here. We can't really claim to be isolated from the world. The health of the globe affects all of us. And I think the other point I wanted to add is that there are so many conditions that exist on a global scale that we don't see as much in the US, because things like preventable blindness, for example, where there are interventions that are and preventive measures that are very inexpensive, and yet this is still happening. And so I think that there are still a lot of issues globally that people living in our context just aren't really aware of, but are causing huge suffering, and with just really a small amount of investment, we could end that suffering forever. And so for me, that's what's really compelling about working in global health, is being able to say, like, no, these are some conditions that we have essentially wiped out in the US, and now let's help the rest of the world get to that point as well.
Okay, fantastic. This is a fantastic evening for me. I've learned a lot, and I think this is a terrific panel. I think I can look right down the line here and think the future is very, very bright. And I would like you all to join with me in thanking them for their time and their effort.